Happy day! For this lecture video, we will be discussing nursing care of a family during labor and birth. To start with, I will be sharing to you a verse in the Bible found in Romans 8 verse 22. It says, "For we know that all creation has been groaning as in the pains of childbirth right up to the present time." Paul here compares our experience on earth as like labor pains. According to Google, labor pains of student life include depression, academic challenges, financial struggles, relationships, accessibility to school, test anxiety, abolition, time management, budgeting, stress, roommates, illnesses, sleep deprivation, lack of right resources, homesickness, distraction, difficulty with schoolwork, social isolation, learning differences, balancing communication, learning disabilities. All these are challenges in a student's life. But these challenges remind us of three things, three life lessons. Number one, you need God. You cannot go through this life alone. You really need Him in all those labor pains. It also reminds us that this world is not our home. This is just a temporary place for us, and our ultimate goal is to be in heaven. Romans 8 verse 18 also reminds us to be joyful, even though we experience labor pains, because the pain that we are feeling cannot compare to the joy that is coming. Hope that you will be inspired by these verses, that whatever labor pains you are going through in this college life, you will be going to feel joy, success if you stay in God. Now let's go to our topic. The objectives for this lecture include describing the onset of the 5 P's of labor and the role of each P in labor, and also to formulate a nursing care plan related to the physiologic and psychological aspects of labor and birth. And of course, we also aim to implement this nursing care plan during labor and delivery, and we will be able to evaluate the expected outcomes and the effectiveness of the care that we give to the patients who are in labor and delivery. So what is labor? It is defined as the series of events by which uterine contractions and abdominal pressure expel a fetus and placenta from the uterus. So there are two powers that expel the fetus inside the uterus, and those are uterine contractions and abdominal pressure. So how does labor begin? So there are around 5 theories on labor that explain how it occurs. So number 1, when uterine muscles get stretched with fetal growth, with the increasing growth of the fetus and increasing amniotic fluid, it becomes irritable and contracts to expel the contents. And we know that the uterine content is the fetus. Number 2, by the way, that was called uterine myometrial irritability or uterine stretch theory. Number 2, progesterone. Progesterone is the hormone of pregnancy, and it relaxes uterine muscles. So you just remember that if there is low progesterone, the opposite of relaxation will occur, and that is contraction. So during late pregnancy, progesterone decreases and uterine muscle stimulants increase. Therefore, contraction happens. Number 3, oxytocin theory. Oxytocin is secreted by our posterior pituitary gland, and once there is pressure of the fetal head on the cervix, it stimulates the posterior pituitary gland to secrete the oxytocin, and we know that oxytocin stimulates uterine contractions. So that is the oxytocin theory. Estrogen, fetal hormones, and prostaglandin also are all hormones that stimulate uterine contraction. And during late pregnancy, these hormones increase, therefore stimulating uterine contractions and making labor commence. And lastly, the theory of aging placenta. It is told that as the placenta matures, more pressure is exerted on the fundal portion, and this is the usual placental site and the most contractile portion of the uterus. So diminished blood supply to the area causes contraction. So as the placenta ages, contraction also occurs. So this diagram describes the theories that were explained earlier. So we can see here that the hormones that promote uterine contractions include oxytocin, estriol, which is the precursor of estrogen, and prostaglandin. And the low progesterone also promotes uterine contractions. So let us now proceed to the components of the labor process. These are the 5 P's. In earlier textbooks, these were only called 4 P's, but research had added another P to make it 5, and this 1 P is also very important that contributes to the labor process. So the 5 P's are passenger, passageway, powers, position, and psyche. So let's talk about the first P, that is the passage. This is the route a fetus must travel from the uterus through the cervix and vagina to the external perineum. And it is made of the soft passageway and the bony passageway. The soft passageway consists of the cervix, the vagina, and perineum, and the bony passageway consists of the pelvis. So these are the bones that make up our pelvic bone. So we have to note here the sacrum, the ischium, the symphysis pubis. Those are the landmarks that we have to remember, and these are very integral to check if the passageway of a mother is adequate for the fetus to pass through. So we're talking here about the sacrum. The sacrum, this is located in the anterior part of the mother, anterior portion of the mother. We also have here the pubis. This is the anterior part of the mother, and this is very important also to determine the position of the baby. And here we have the ischium. So I just want you to take note of the ischial spine. These two projections at the side. This is the narrow part of the pelvis, which may prevent the fetal head from entering the pelvic inlet. And it's very important to check the measurement of this ischial spine to see if the fetus can pass through. This is also the point of engagement, or the touching of the fetal head to the cervix, which indicates that a baby is already ready to deliver. So we can see here that the pelvic bones are the hard passageways, but God is so good. He made the sacrococcygeal joint mobile during the labor process so that it can allow fetal head delivery. And of course, the hormones estrogen and relaxin, these soften the pelvic cartilage and increase strength and elasticity of the pelvic bones so that the baby can really be expelled from the mother's uterus. I will be showing a video here that shows the difference of a male's pelvis from a female's pelvis, and we can appreciate how God created women to be very special, to be the ones who will carry babies and not men. So let's watch this video to check and to see what the differences between the male and the female pelvis.
The hip bones spread outwards and become flatter. But more important is what happens to the space in the middle. It opens, ending 4 centimeters wider than men, just enough for a baby's head to squeeze through.
Ending 4 centimeters wider than in men, just enough for a baby's head to squeeze through.
So God really designed the pelvis of women to be a gynecoid type. But of course, sin has already made a lot of differences in the structure of our bodies, that some women have the android type, which should be the male pelvis shape, or the anthropoid type, or the platypeloid type. So, but we can see that the most ideal for vaginal birth is the gynecoid type, which is found in 50% of women. It is rounded, it is wide, and it is very, very ideal for vaginal birth. We also have the anthropoid, which is an oval shape. This is quite narrow, but vaginal birth is still possible with assistive devices such as forceps, and it prefers the occipito-posterior or occipito-anterior position. Platypeloid pelvis is flat, but it is wide, and it is still possible for vaginal delivery. But of course, it poses more challenge and risk for the babies. But for the android, which is usually the male pelvis, this is heart-shaped and narrow, and thus the usual mode of birth for this type of pelvis is cesarean section. Vaginal delivery may be attempted, but it may be very, very difficult even with the use of assistive devices. So once the OB obstetricians see that your type of pelvis is heart-shaped, they usually discourage giving birth through vaginal delivery. It is also false to say that women with wider hips can give birth easily than those with smaller hips, because actually the size of our hips that we see visually is the false pelvis. It is not the true pelvis. So you cannot measure the size of the pelvic inlet just by visually observing a woman. You really have to measure the true pelvis, which is the pelvic cavity. So the true pelvis is divided into three pelvic planes. We have the pelvic inlet, the mid-pelvis, and the outlet. So the pelvic inlet has the anteroposterior diameter, which is around 11 cm at its narrowest size. We also have the mid-pelvis or cavity that contains the plane of greatest diameter and the plane of least diameter, and the outlet, which is the actual anatomical outlet where the baby passes out, going to the soft passageway. So we have the inlet, the mid-pelvis, and the outlet. This is a view of the three pelvic planes from the side and from the front. So these are also the three planes which are measured to see if the cephalopelvic diameter is adequate to deliver a baby via normal spontaneous delivery. So the inlet is measured from the upper border of the sacral promontory to the symphysis pubis, and that is for the true anteroposterior diameter. And for the diagonal diameter, we measure the lower margin of the symphysis pubis to the sacral promontory. So measurement of this can be done during internal examination, or we call that the sterile vaginal exam. The midplane, in turn, is the distance between the two ischial spines. So this is these are the two spines that we measure the distance between the two, so that we can see if the fetal head can fit. And lastly, the outlet is measured by measuring the distance between the intertuberous spines, and we use the pelvimeter to measure the distance between these two and also check if the fetal head can pass through. So for the normal centimeters, these are the figures. Pelvic inlet, from front to back, usually it measures 11 cm. From side to side, it measures 13 cm. And oblique or slanting, that is 12 cm. For the midline or mid cavity, we have 12 for anteroposterior, 12 for transverse, and 12 cm for oblique. And for the pelvic outlet, anteroposterior is around 13 cm and transverse is around 11 cm. So do we have to memorize? No, we don't have to memorize these figures, but we just have to understand that any deficiency of even just 1 centimeter from these ideal figures will warrant challenges in labor and delivery and can already be called cephalopelvic disproportion. And depending on the degree or severity of the disproportion, we will know if the mother is capable for vaginal delivery or will need assistive devices or probably warrant cesarean section. So it's very important that the passageway be adequate for labor and delivery to happen without complications. Now let's go to the second P. This is the passenger. When we talk about the passenger, this refers to the fetus. And we also have to note that the fetal head has the widest diameter. So let's check the structure of the fetal skull. It consists of 8 bones: the ethmoid bones, sphenoid bone, frontal bone, parietal bone, a pair of parietal bones, a pair of temporal bones, and the occipital bone. They are connected with each other. So we have fetal landmarks, which consist of fontanelles and sutures. So what is the beauty of these fontanelles and sutures? Again, this is a creation of God to make sure that the head can pass through the passageway safely. So fontanelles are spaces between the bones that remain open in babies and young children. And the sutures are the elastic, fibrous, and strong tissues that hold the bones together. Fontanelles and sutures also make molding possible. So what is molding? This is rather the overlapping of skull bones along the suture lines, which cause a change in the shape of the fetal skull to one that is long and narrow, and a shape that facilitates passage through the rigid pelvis. So even though there are changes in the shape of the head of the fetus, these changes are just temporary, and after a few hours after birth, the shape will return to a rounded head. Okay, we can also see in this slide the different diameters of the fetal skull depending on how it is positioned. So we can see here biparietal or transverse. This is the most ideal position of a fetus in a cephalic position or head presentation. We can see here that the neck is flexed. So only the occiput is seen at the pelvic outlet. So occiput, when we say occiput, that is the back of the head. So when that is the presentation, because the neck is flexed, you can see the back at the pelvis. That is the smallest diameter, and it only measures around 9.25 cm, and it really fits well in the ideal passageway for the pelvis. We have another position, the suboccipito-bregmatic. Okay, it's just a little bigger than the biparietal. The head is moderately what do you call that? Moderately flexed. Okay, so 9.5 cm. We have also the occipito-frontal measurement, which we can see here. The forehead to the back of the head is the presentation in the pelvic outlet. So that already measures 12 centimeters, which is a bit bigger from the usual size of the pelvic bone or pelvic outlet. So this will show more challenges in the delivery of the fetus and require assistive devices. But still, vaginal delivery is possible with a little trauma or bruises on the forehead and the head of the baby. And lastly, Another head presentation is the occipitomental, wherein the chin to the forehead is the presenting part here in the pelvic outlet. So this is the chin and the head. So it measures around 13.5 cm, and this is quite bigger than the usual pelvic outlet that is expected. So we expect again bruises or a little bit trauma in the face of the baby, but again this is temporary and vaginal delivery is still possible. So this is what I was talking about when I talked about molding. You see here the head of the baby minutes after birth. Here it is quite elongated, but after 24 hours it went back to the round shape. So molding only was done so that the baby can facilitate passage outside of the uterus. But once the baby is out, the normal shape of the head is attained. So now let's talk about the terms that are being used when we talk about fetal presentation or position. So number one is fetal attitude. So this is the degree of flexion that a fetus assumes during labor, or the relation of the fetal parts to each other. So when we say flexion, you are bringing a body part closer to another body part. So for example, you flex your neck, you flex your arms like this, or you can flex your hips when you bring your knees to your chest. You can flex your knees when you kneel. So just imagine your body when you are sleeping in a fetal position. Most of your body parts are flexed. That is the best position for a fetus because more flexion will also make the fetus move better when it descends going to the cervix. So when we talk about flexion, that is fetal attitude, and the more flexion, the better. So now we go to the next term. We call this the fetal lie. When we talk about the fetal lie, just think of the spine. This is the relationship between the long axis of the fetal body, or the fetal spine, to the long axis of the mother, or the maternal spine. So just imagine this is the maternal spine, this is the fetal spine, where they are parallel to each other. You call it a longitudinal lie. And that means it's either the buttocks up here, or the head up here, or the buttocks down, or the head down. So that is longitudinal line. But if the maternal spine is this and the fetal spine direction is like this, we call that transverse line. And usually fetuses that are in a transverse lie position are encouraged to have cesarean section because they have a more difficulty for vaginal delivery. Next term is fetal presentation. This is the body part that will first contact the cervix. So it can either be the fetal head, the buttocks, the chin, the shoulder. Okay, we will learn more of that earlier. But when we talk about presentation, just think, what body part of the fetus will come in contact with the cervix first? And lastly, fetal position. This is the relationship of the presenting part of the fetus to a specific quadrant or side of the mother's pelvis. So that's how you can imagine how does a fetus position himself before delivery. That is the fetal position. For more emphasis, let's talk about fetal attitude. We said better flexion, better attitude. So we can see here in the first picture, that is a fetus in a fetal position. Neck is flexed, arms are flexed, hips are flexed, and knees are flexed. That is what we call the vertex position, complete flexion, and that is the best attitude. We can see here in the second picture, this is the military or sinciput position. Moderate flexion, because you can see here, The hands are flexed, the knees are flexed, the hips are flexed, but the head has a moderate flexion. So just like the military position, chin up, it's not flexed. So this is only moderate flexion. Next, we have the partial extension. Instead of flexing the neck, it is partially extended. So that happens in a brow position, wherein the brow is the presenting part of the fetus. And lastly, the complete extension, or we call this the chin presentation here, or some books call it face presentation, because it's the face that is presenting. Okay, so that is the poorest fetal attitude. Fetal attitude can also be applicable to the breech position. So here in the breech position, the best fetal attitude is the second picture, wherein the neck is flexed, arms are flexed, hips are flexed, and knees are flexed. Moderate attitude is this first picture. Hips flex, but the knees are extended to the chest. And the poorest attitude is here, wherein the knees and legs are extended. So we can see that if the fetus has a poor attitude, it will have more difficulty to move or to descend down normally, spontaneously from the vagina. Okay, I already discussed fetal line. Again, when the fetal spine is perpendicular to the maternal spine, it's called longitudinal line. So both the first and second picture are longitudinal line. But if the fetal spine is perpendicular to the mother's spine, that's what we call transverse line. Now let's talk about fetal presentation. Again, how did we define presentation? It is the part of the fetus that comes in contact with the cervix first. So we can see here, what comes in contact with the cervix first? It's the head. And once it's the head that comes in contact first, we call that cephalic presentation. So for cephalic presentation, it can either be vertex or the occiput. It can be the brow. It can also be the face, or it can be the chin. So either, as long as it is the head that is presenting or touching the cervix, any part of the head, we call that cephalic presentation. Here, what is in contact with the mother's pelvis? It's the sacrum or the buttocks. We call that breech presentation. And for this one, in a transverse line, what is in contact with the cervix first? It's the shoulder, and we call that shoulder presentation. So for the cephalic presentation, again, I said it can either be vertex with the occiput, the most ideal, with the complete flexion. It can be military presentation with the moderate flexion. It can be brow presentation, poor flexion, or the face or chin presentation, full extension. So all of those are called cephalic presentation. This is an example of the shoulder presentation. And these are the types of breech presentation. It can either be complete or incomplete. When we talk about complete, it is a breech fetus in good flexion or universal flexion. The knees are flexed, the hips are flexed. Here, the knees, the hips, the arms are flexed, and the knees and the neck, rather, is flexed. So this is what we call complete breech, good flexion. And we have three types of incomplete breech. We have the frank breech, wherein all body parts are in flexion except for the knees, which are extended. We also have the footling breech, wherein the knees are extended and the hips are also extended. So we can see one foot or 2 feet that are presenting in our pelvic outlet. And we also have the kneeling breech. Oh, this breech has extended hips and flexed knees, like when you are kneeling in prayer. So, yes, sometimes you will really kneel hard in prayer so that you can deliver the baby spontaneously through vaginal delivery, because these are more challenging presentations. Again, there are cases where in breech presentation, a fetus in breech presentation can be delivered vaginally, but of course, it is safer to deliver them through cesarean section. Now let's talk about fetal position. So fetal position is indicated by an abbreviation of 3 letters. So let's talk about these 3 letters. The first letter is referring to the mother's right or left. So always remember the mother's right is your left side, and on your right side is the mother's left side. So it's always the opposite of the side of your body. So when we talk about first letter, mother's right or left side. Now the middle letter. Middle letter refers to the presenting part. So what are the presenting parts or possible presenting parts? It can either be the occiput or the back of the head. It can either be the mentum, letter M, or the chin. It can be the sacrum, which is your buttocks, or it can be your acromion process, which is your shoulder. So those are the 4 possible presenting parts that may be used in the middle letter. And lastly, the last letter. These are the landmark points, anteriorly, posteriorly, or transverse, referring to your pelvis. So when we say anterior part, that is the symphysis pubis. Posterior part is the sacrum. And transverse is more on the left and right side of the pelvic bone. So for emphasis, first letter refers to the right or left side of the mother. The middle letter refers to the presenting part, which can either be occiput, mentum, sacrum, or the acromion process, or the scapula. And the last letter refers to the landmarks. It can be posterior, or the sacrum, anterior, or the symphysis pubis, or it can be the sides of the pelvic bone. So let's practice. Look at the first picture. Check. What is the presenting part? Yes, you have to know what is the presenting part first. You have to check what is the middle letter first. So we can see here, our presenting part is the occiput. Okay, where is the occiput located? Is it in the mother's right, or is it on the mother's left? So the answer is, it is in the mother's left. Okay, so is it in front of the mother, the side, or the back? It is at the back, so we call it posterior. So what is your answer? It is left occiput posterior, or LOP. Okay, let's go to the next. What is your presenting part? Yes, it's again the occiput. So you have to write the letter O. Is it right or left? Yes, it's still left. And you can see that the spine cannot be palpated or cannot be seen in front. So you can see that the side of the pelvis touches the occiput. So we call this left occiput transverse. Okay, how about for this next picture? What is the presenting part? Occiput. Left or right? The occiput is towards the left. Okay, so it's left. Is it anterior or posterior or transverse? So you can see here, the spine is already seen. So it means the occiput of the head is towards the front. So how do we call it? Maternal side is left, presenting part is occiput, and the landmark is anterior. So we call it left occipito anterior, or LOA. Okay, now you can do the rest for the following pictures. Presenting part, maternal side, landmark. Is it anterior, posterior, or transverse? If you answered ROP, or right occipito-posterior, you are correct. Now go to the next. Presenting part, right or left? What is your landmark? Anterior, posterior, or transverse? If you answered right occipito-transverse, or ROT, you are correct. Next, presenting part, right or left? Landmark. Check the spine, it's towards the front. So it means your occiput is towards the anterior area of the mother. So we call this right occipito anterior. Now let's go to the next. Here, what is your presenting part? Okay, you can see here the face. So, your presenting part that touches the cervix is your mentum. What letter do we use for mentum? Letter M, that's right. So check the mentum. Is it towards the right or towards the left? You are correct if you said right. Now check, is it towards the front or anterior, or is it towards the back? If you answered anterior, you are correct. And our position is right mentum anterior, or RMA. Now let's go to the next picture. What is the presenting part? Yes, it's the face. And again, our presenting part for the face is the chin. What letter do we use for the middle letter? It's letter M. Okay, now, is it towards the right side or the left side of the mother? Okay, if you answered right, you are correct. Now, can you see the mentum of the baby? Yeah, you cannot see it because it's positioned towards the back. So we call this position right mentum posterior, or RMP. Okay, let's go to the next picture. What's your presenting part? Right or left? What's your landmark? Anterior or posterior or transverse? Okay, you can try to write your answer and then check. Now let's see. If you answered left mentum anterior, you are correct. Okay, how about the next picture? What's your presenting part? Yes, it's the buttocks. So the buttocks, when we talk about the buttocks, your presenting part is the sacrum. That's your middle letter S, a big S and a small A. Is the buttocks towards the right or the left? Okay. Is it towards the front or the back? Okay, you can see that the buttocks is in the left part and it is towards the front because you can see the spine is already visible. So the position is left sacrum anterior, or LSA. Next, what is your presenting part for the first picture? Again, it's the sacrum. Left or right? Yes, still the left. Can you see the sacrum? Yes, you cannot see it because it's at the back. So your position is left sacrum posterior, or LSA. Oh, the next picture. What is your presenting part? It's the head. So we have the occiput. Is it towards the right or towards the left? Okay, is it anterior, posterior, or transverse? So what is your fetal position? It's right occiput posterior. And here, the last picture, what is your presenting part? Is it towards the right or left of the maternal side? Is it in the anterior, posterior, or transverse part? What is your landmark? If you answered left occiput posterior, you are correct. To add to your pool of knowledge, these are more examples of possible fetal positions. You may want to check it out and imagine so that you will have a more vivid description of the fetus that you are going to deliver. Aside from the fetal positions and presentations, we have also two terms to remember with regards to the fetus. The first term is engagement, or the entry of the widest portion of the fetal head into the opening of the birth canal. Next is the station, or the position of the baby's head measured in the number of centimeters it is above or below the ischial spine. So let's see. Here, as what we learned a while ago in passageway, ischial spine is our station 0. This is the point of engagement. So once the baby is engaged or already entered the widest portion of the pelvic inlet, that is already station 0. 2 inches above it is called the floating stations. So we number it or measure it as negative numbers. So -1 for 1 cm above the ischial spine, -2 for 2 cm above the ischial spine, and so on. If the head is already below the ischial spine, we already use positive numbers. So 1 cm below the ischial spine is +1. 2 cm below the ischial spine is +2. And we call the numbers below the ischial spine as the dipping station. D-I-P-P-I-N-G. Dipping. Because the head is already dipping. And once it reaches +3, 4, and 5 cm, we already call the station as crowning, because you can already see the head of the baby when you have your visual inspection of the perineum. So again, what is your point of engagement? That is station 0. Above it, negative numbers, and we call that the floating stations. Below the ischial spine, positive numbers, we call it the dipping station, and the stations below +3, 4, 5 are called the crowning stations. So how do we determine the stations? Again, we will do the sterile vaginal exam. So when you check the cervix of the mother, you are also checking the position. How high or how low is the baby already? You can already feel the bones at each side of the mother's pelvis and check where is the baby located. And you will be able to report it after your internal exam. So still the same, even though the baby is breached, you can still see what station is the baby already, right? The plane of inlet and the mid-plane, that's it. To better visualize the descent of a baby down the pelvis, let us watch this video. Now let's proceed to the mechanisms of labor. These are the different position changes by the fetus in order to keep the smallest diameter of the fetal head in cephalic presentation, always the smallest diameter of the pelvis. This is also called the cardinal movements of labor. So here we have descent, the baby goes down. Flexion, look at the head, it flexes. Internal rotation, it rotates going inside. And then extension, the head extends. And then external rotation, it rotates going outside. And then it is expulsed from the body, or expulsion. We have made a mnemonic for that. We call it EDFIRE, or in Tagalog, we can say, Edi fire ere, or it translates, okay, so you fire, ere, or push. Okay, Edi fire ere, because it starts with engagement. After engagement, the baby descends, flexes the head, internally rotates its body, extends the head, and then externally rotates its body, and then its expulsion happens from the body of the mother. Let's watch the video so that we can better imagine it. Okay, you can see the view here. One view is from the mother's side and the other one is perineal side. So you can imagine how the head goes out. So this is descent. The head is going down. And then the head will flex. And then the body will internally rotate or going to the midline of the mother. And then the head will extend. Okay, externally rotate after extension. So it will go, rotate away from the midline there. And then eventually the expulsion of the baby outside the uterus. And you say, baby out. Okay, let's go now to the third P. The third P refers to the position of the mother during labor and birth. So just remember, for the first stage of labor, the ideal position for the mother is the left lateral recumbent, or we call it left side lying position. But you can let the mother ambulate if the bag of water or the amniotic sac is still intact. So this position prevents supine hypotensive syndrome or vena cava syndrome. For the second stage of labor, when the cervix is already fully dilated, the best position is lithotomy position. But make sure that when you position the mother in the lithotomy position, there is equal height of the stirrups. The stirrups are padded. You place the legs simultaneously and avoided pressure on the popliteal region so that the mother will be comfortable in that position. So why left lateral recumbent? Here is the reason. When you are in a supine position or lying down flat, you can see that the weight of the baby compresses your vascular structure, specifically the inferior vena cava. Thus, it compresses the supply of blood to the uterus and decreases oxygenation of the fetus. So it's more ideal for you to be in a left lateral position. Why left? Because the heart is towards your left. So you would want to free the vessels that are towards your left. So with this position, the fetal weight is distributed to the left and you are freeing the vascular structures that are vital. Patency is maintained. Yeah. for the aorta and the inferior vena cava. And there is adequate blood supply to the uterus and adequate oxygenation to the baby. So that's why we promote left lateral recumbent or left side lying position for the mother during the first stage of labor when the cervix is not yet fully dilated. But once the cervix is already fully dilated, we place the mother in a lithotomy position. So this is the lithotomy position. Just remember, equal height of stirrups, padded stirrups. What else? Avoid pressure on the popliteal region of the mother, and you place the legs simultaneously in the stirrups so that the mother will be comfortable. Let us proceed to the fourth P. The fourth P is called powers. This is the force supplied by the fundus of the uterus and implemented by uterine contractions, and it causes cervical dilatation and expulsion of fetus. So we talk about the uterine contractions now that bring about cervical dilatation because we want to talk about true labor. So let's talk about true labor. So what is the difference between true and false labor? So here we can see that regularity is different. False contractions begin and remain irregular, while true contractions begin irregularly but eventually become regular and predictable. False contractions are felt first in the abdomen and they just remain confined to that area. But true contractions are felt first in the lower back and they sweep around to the abdomen in a wave. So it's the whole back and the abdomen having pain. And then once you sleep or ambulate or walk, false contractions disappear. But for the true contractions, no matter what kind of activity you take, it will never disappear. False contractions also do not increase in duration, frequency, or intensity, but true contractions increase in duration, frequency, and intensity. And the most important sign is false contractions do not achieve cervical dilatation. So there's no dilatation of cervix even though there are contractions. But for true contractions, the cervix eventually achieves dilatation. So what is the full cervical dilatation that we want to the mother to achieve before delivery? That is 10 centimeters. So true contractions achieve cervical dilatation. That's the most important indicator of a true versus a false contraction. Now, what are the phases of labor contraction? So we can see here there are three phases: the increment, acme, and decrement. So when we talk about increment, increase. So this is the part where the intensity of the contraction increases or goes up. Acme. Acme stands for the strongest contraction. When we see the letter A, it's going up. So that is the strongest or the peak of the contraction. And lastly, decrement. That is the time when the contraction decreases or slows down or the power goes down. So those are the three phases of labor contractions: increment, acme, decrement, going down. So we have also terms to remember when we are monitoring uterine contractions. Number one is duration. This is from the beginning of the contraction to the end of the same contraction. So you have to time this one in seconds, the duration, from the increment to the decrement of the same contraction, the beginning to the end of one contraction, of the same contraction. How about the frequency? We express this in every blank minutes. Okay, every blank minutes. So this is from the beginning of one contraction to the beginning of another contraction. So you say the contraction is every 3 minutes, every 2 minutes. So that is the beginning of one contraction to the beginning of another contraction. And the interval, this is the resting time between contractions that allows for placental perfusion. So usually this is expressed in seconds. So two types of powers are needed to have an effective delivery. So the primary power is the uterine contractions itself, and the secondary power refers to the maternal efforts and the intra-abdominal pressure. So even though there is adequate contractions, but the mother doesn't know how to push, it will still have more challenges. So it has to be a combined power of these two powers. Yeah, and with the help of your proper coaching, the mother will be able to achieve the best effort that she can so that it can help the primary power, which is the uterine contractions, to expel the baby from the uterus. So let's talk about the cervical changes during contraction. First is effacement, or the shortening and thinning of the cervical canal during pregnancy, and it shortens and thins to from 1 to 2 cm. During pregnancy, it's just 1 to 2 cm, and then it eventually thins until you cannot see it anymore. Okay, that is effacement, thinning. And after it thins, it enlarges and widens to open a few millimeters wide to one large enough to permit passage of fetus. So the enlargement process is called dilatation. So effacement is thinning, dilatation is enlargement or widening of the canal. So let's see. This is effacement. At first, your cervix is not effaced or dilated. You can see the thickness here. And then this one, it is already 50% of the original size. So it is a 50% effaced. But you can notice it is not yet widened. So it's not dilated. This one, you can no longer see the thickness of the cervix. It is 100% effaced. And now there's a small space in between. You call that dilatation, and it is dilated to 3 cm. And when you see that it is fully dilated, this is 10 cm. The head can now pass through. So effacement, thinning or shortening of the cervical canal. Another view, this one is not effaced, 50% effaced. Maybe this is around 30% effaced. Oh, no, this is 100% effaced with a little dilatation, maybe 3 cm. And then this one is fully dilated and fully effaced. Okay, how about dilatation? When we talk about dilatation, widening of the cervical canal. So it ranges from 1 cm to 10 cm, as big as a cantaloupe melon. So when we do your sterile vaginal exam, you use these 2 fingers. Of course, you use your thumb and your 4th finger or ring finger to open the labia. Then you insert the 2 fingers sideways and then up, and then that's when we will start measuring. How many cm? 2 cm, 4 cm, 6 cm, 10 cm. That's how wide the cervical canal widens, the cervix, yeah, so that the baby can pass through. Okay, another visualization of how dilatation takes place from 1 cm to 10 cm. So we can see now that when we do our sterile vaginal examination, we can already assess many factors or many evaluation aspects of the progress of delivery. Number 1, you can check the effacement or the thinning. You can check the dilatation. And number 3, you can also check the fetal station. So what station is the baby now? Station 0, -1, +1, crowning, floating. Those are the terms that you can hear after performing sterile vaginal exam. And you will understand now and you will visualize the progress of labor the mother is going through. So now let's talk about the last P, or the psyche. These are the feelings a woman brings into labor, or her psychological state. So the mother may be feeling apprehensive or afraid or excited or in awe about what's happening in her life right now. So to make sure that we manage the psyche of a woman in labor, we have to encourage them to have prenatal visits so that they know what they will expect during labor. They can ask questions, and after labor, you can debrief them about what happened. So it's very important that you talk, you communicate with the mother about her psyche. So those are the 5 P's: passageway, passenger, powers, the position, and the psyche of the mother. These 5 components contribute a lot to how the mother will go through labor and delivery.